Hello friends, I am Dr. Saurabh, Senior Consultant Spine Surgeon from JP Hospital, and today we will be talking about acidity caused by NSAIDs. So as we all know that NSAIDs cause a lot of acidity to most of the patients to whom they are prescribed. So we'll be talking about how to prevent this acidity and how to manage this acidity in patients who are prescribed NSAIDs. Now, NSAIDs cause damage to the gastrointestinal epithelium by a lot of mechanisms. The most common mechanisms of these are topical irritation to the gastric mucosa. Apart from that, they result in suppression of the blood flow to the gastric mucosa. They inhibit the reparative properties of the gastric mucosa. They damage the barrier of the gastric mucosa, and apart from that, they also lead to reduction in the prostaglandin synthesis of the gastric mucosa. Most common medicines which are used for the treatment of acidity and gastritis are PPIs, the proton pump inhibitors, as well as H2 receptor antagonists. Now, since the introduction of omeprazole in 1989, it has become the first choice medicine for the treatment of NSAID-induced acidity and gastritis. PPIs have become the mainstay of treatment for the treatment of NSAID-induced acidity and gastritis. They have an excellent patient tolerance, excellent safety profile, and they are much more superior to acid suppression properties as compared to the prior options which were available. So when we compare the different PPIs, they are almost same, and there is no difference in their effectiveness and safety profile. Omeprazole also finds a mention in the WHO list of antacid and anti-ulcer medication. So coming to the H2 receptor antagonists, most commonly famotidine and ranitidine, a meta-analysis of 14 trials shows that they are protective but at higher doses. At commonly prescribed doses, they are protective against duodenal ulcers. The use of H2 receptor antagonists reduces gastric acid production by 37 to 68% over 24 hours. In a recent update, the FDA has asked all manufacturers to withdraw all prescription and over-the-counter ranitidine. This is due to the presence of a contaminant called as N-nitrosodimethylamine (NDMA). This contaminant tends to increase over a period of time and tends to increase with exposure to high temperature, which can result in unacceptable level of exposure to consumers to this contaminant. On comparative analysis, PPIs are the most potent inhibitors of gastric acid secretion as they result in direct inhibition of the acid pump. So apart from being long lasting, the proton pump inhibitors are able to maintain much better postprandial and nocturnal control of gastric pH as compared to the H2 receptor antagonists, and this is of much clinical importance. Tachyphylaxis can develop with even 3 to 5 days of use of H2 receptor antagonists. It has been found that consistent use of H2 receptor antagonists over weeks and months reduces their acid suppression properties by about half. A study by Chen et al. Found that the famotidine group had 2 times higher incidence of GI symptoms as compared to the omeprazole group. They also found that omeprazole group was 3 times more potent in the treatment of recurrent ulcers and erosions as compared to famotidine. So to conclude, omeprazole has consistent patient tolerance, excellent safety profile and superior acid suppression properties, which makes it the first choice drug for the treatment of NSAID related acidity related problems, and therefore it is also mentioned in the WHO list of essential medicines for acidity and gastritis. So omeprazole 20 mg daily has shown up to 80% reduction in ulcers while continuing long-term NSAIDs. Moreover, I would like to highlight that patients taking co-therapy with omeprazole had much less GI symptoms and much better protection against GI ulcers and erosions as compared to the famotidine group while they were taking long-term NSAIDs. Thank you.